times, people ask the question, why should we focus on prevention? There are a range of thoughts, opinions, and views about the concept of prevention. As a matter of fact, many of Ohio's communities have recently focused on the importance of promoting prevention education. And while promoting prevention education is essential to healthy environments, it is merely one strategy within the scope of prevention. Let's take a look at what prevention is really all about. Prevention promotes the health and safety of individuals and communities. It focuses on reducing the likelihood, delaying onset, slowing the progression, and/or decreasing the severity of mental, emotional, and behavioral health disorders. Prevention involves empowering individuals, families, and communities to meet the challenges of life events and transitions. Prevention focuses on the physical, social, emotional, spiritual, and cognitive well-being. Prevention also promotes safe and healthy behaviors and lifestyles. Primary prevention is an upstream approach focused on stemming the flow of people with problems who need services by improving the physical and social environment so that fewer people are impacted by behavioral health conditions. A primary prevention approach requires looking at the role of social, physical, economic, and cultural factors play within the entire scope of prevention. Early intervention, which is previously known as secondary prevention, is an integral part of the continuum of prevention-based services. These interventions happen after serious risk factors have already been discovered very early in disease progression, soon after diagnosis. The goal here is to halt or slow the progress of disease in its earliest stages. Recovery support or relapse prevention, previously known as tertiary prevention. This focuses on helping people manage complicated, long-term health problems such as diabetes, substance use disorders, mental health disorders, etc. The goal is to prevent further physical deterioration and maximize quality of life. Therefore, recovery services are not considered prevention services. Prevention services are a planned sequence of culturally appropriate, science-driven strategies intended to facilitate attitude and behavior change for individuals and communities. They can be direct or indirect. Direct services are interactive prevention interventions that require personal contact with small groups to influence individual-level change. For example, classroom-based programs, parenting programs, community trainings, etc. Indirect services are population-based prevention interventions that require sharing resources and collaborating to contribute to community-level change. For example, compliance checks, media campaigns, advocacy, etc. The term primary prevention is reserved for interventions designed to reduce the occurrence of new cases of mental, emotional, behavioral health disorders. Two criteria define primary prevention efforts. First, prevention strategies must be intentionally designed to reduce risk or promote health before the onset of a disorder. And second, strategies must be population-focused and targeted either to a universal population or to subgroups with known vulnerabilities.
Prevention is not drug or paraphernalia displays, scare tactics, stories by individuals in recovery, general awareness or statistics, information on drugs and their effects such as posters of drugs, needles and arms, overdose victims, pictures or videos of car crashes, etc., teaching signs and symptoms of addiction, information on treatment and recovery, program promotion, relapse prevention, and aftercare. So, remember that prevention is none of these things. Therefore, primary prevention services exclude clinical assessment, treatment, recovery support services, relapse prevention, and case management. Primary prevention should include a variety of strategies that prioritize populations with different levels of risk. Specifically, prevention strategies can be classified using the Institute of Medicine model of universal, selective, and indicated, which classifies preventative interventions by priority population. Universal prevention. targeted to the general public or a whole population group that has not been identified on the basis of individual risk. The intervention is desirable for everyone in that group. Selective prevention, targeted to individuals or to a subgroup of the population whose risk of developing mental, emotional, or behavioral disorders is significantly higher than average. Indicated prevention, targeted to high-risk individuals who are identified as having minimal but detectable signs or symptoms that foreshadow mental, emotional, or behavioral disorder, as well as biological markers that indicate a predisposition in a person for such a disorder but who does not meet diagnostic criteria at the time of intervention.
There are 6 CSEPP strategies: education, environmental, community-based process, alternatives, information dissemination, and problem ID and referral. Education. This strategy focuses on the delivery of services to target audiences with the intent of influencing attitude and/or behavior. It involves two-way communication and is distinguished from information dissemination by the fact that interaction between educator, facilitator, and participants is the basis of the activities. Activities influence critical life skills, social emotional learning, including decision-making, refusal skills, critical analysis, and systematic judgment abilities. Prevention education is not equivalent to psychosocial education, which is helping a diagnosed individual increase awareness and knowledge of the nature, extent, and harmful effects of their behavioral health disorder. Environmental. This strategy seeks to establish or change standards or policies to reduce the incidence and prevalence of behavioral health problems in a population. This is accomplished through media, messaging, policy, and enforcement activities conducted at multiple levels. Community-based process. This strategy focuses on enhancing the ability of the community to provide prevention services through organizing, training, planning, interagency collaboration, coalition building, and/or networking. Community-based process activities are essential to effectively implementing an environmental strategy. Planning and meeting must result in the selection of either a prevention education or environmental strategy to allow for the return on investment of the community's resources invested in the coalition building, capacity building, and planning processes. Alternatives. This strategy focuses on providing opportunities for positive behavior support as a means of reducing risk-taking behavior and reinforcing protective factors. Alternative programs include a wide range of social, cultural, and community service volunteer activities. Alternative activities must be conducted as part of a larger, comprehensive prevention effort. Otherwise, they're merely a fun activity that cannot be distinguished from healthy participation in community life. Information dissemination. This strategy focuses on building awareness and knowledge of behavioral health and the impact on individuals, families, and communities. It is the dissemination of information about prevention services. Information dissemination is characterized by one-way communication. This strategy is not designed to be conducted alone, but is part of a comprehensive, evidence-based approach. Information dissemination provides a foundation for community-based process to engage and mobilize communities into action. Although prevention strategies can be implemented without the foundation of information dissemination and community-based process, these interventions tend to lack the benefits resulting from broad-based community support and opportunities for expansion and quality improvement. Problem identification and referral. This strategy focuses on referring individuals who are currently involved in primary prevention services and who exhibit behavior that may indicate the need for a behavioral health assessment. This strategy does not include clinical assessment and/or treatment for behavioral health disorders, or SBIRT, screening, brief intervention, and referral to treatment services. This strategy is also not designed to be conducted alone, but is part of a comprehensive, evidence-based approach.
In an effort to obtain the greatest impact in Ohio's communities from CSEPP 6 prevention strategies, the focus is on the intended level of change. Therefore, Ohio believes a deeper dive is necessary and allows for the conceptualization of a more integrated model. Within this integrated model, prevention education and environmental strategies are seen as the primary prevention strategies and have the strength to influence attitude, behavior, and status on their own. The other 4 strategies, community-based process, alternatives, information dissemination, and problem ID and referral, support the implementation of these 2 primary strategies. All 6 in appropriate proportions are needed as part of a comprehensive prevention approach. So, let's review. Education and environmental strategies are the 2 main prevention strategies because they have the intervention strength to influence attitude, behavior, and status. Therefore, conducting either prevention education of environmental strategies alone is considered implementing primary prevention. The other 4 CSEPP strategies, such as community-based process, alternatives, information dissemination, and problem ID and referral, support the implementation of these 2 primary strategies and were not designed to be conducted alone, but as part of a comprehensive evidence-based approach.
Ohio recognizes that prevention is part of the continuum of care. Effective prevention decreases risk factors and enhances protective factors. Prevention requires the adoption of known effective prevention practices, policies, and strategies. Collaborative systems of prevention work better than service silos. In summary, all 6 strategies are needed as part of a comprehensive prevention approach. Communities receive the greatest benefit when they combine all 6 CSEPP strategies in the appropriate balance to address the needs of universal, selective, and indicated populations in their own unique communities.